Okay, good morning. Thanks to PK and Michelle, everybody else for the invitation. Great to be with such a great panel, except for Mac. I was asked to talk about dealing with thrombosis within ISR, which is something we need to be cognizant of, and I've learned that the hard way. These are my Photoshop pictures of Chicago. Come visit us anytime. These are my unbiased slides here. So let's talk about potential thrombosis. So what's the issue? We have a lot of patients with stents. We know that. We need them. I think the general trend people claim is they're putting less and less, but we do need them. Bare metal stents, they go in. And we try to avoid them, but they go in, and the ISR is going to be the problem we're dealing with. That's what this whole session's about. Slides have talked about what happens within the stent. You get that hyperplastic response, you get collagen deposition, so on and so on. And you can see the layers of tissue that forms within there, and the time frame can be different. But when you look at it, this is a patient who's had some spot stenting, always at the outside hospital, never at my hospital. That's where all these issues come from. Had a subacute presentation of pain, coolness, and the right side motor's intact. So you see the pictures, I don't know if you can see it well, but there are stents here in the proximal SFA. And then there is patency, if you look back here, coming down up to the stents in the distal SFA pop. Runoff is kind of reconstitutes in the posterior tibial. You can see some prior surgical clips from bypass that went down. So what are our options with these patients, right? We can cross it, balloon it, reline the stents, atherectomy, balloon it, DCB it. You can do a whole slew of things, and we don't have the exact answers of what to do. A lot of us figure out anecdotally. In the past, we'd cross it, just balloon it, and then reline it. That's what several years ago. Sometimes you get lucky with that, but sometimes you will cry. Well, the patient and you will cry when you have problems and you have embolization. Over time, we changed that to cross it, put an infusion catheter, lyse it overnight, and then bring back the next day. That could be 1 day, that could be 2 days. Typically past 3 days, you're just playing with numbers for no reason at that point. But this is a patient years ago. We put an infusion catheter, drip it overnight, and as you can see, within a day or two, you might clear up quite a bit. And it's important to understand that because a lot of times you may have different age clot in there, and if you don't respect that, you will lose things. You will take a clot of Kent into a clot of Kant, so you don't want to do that. It's very important, and the runoff looks good. So lysis does work, but you have to think about ICU. You have to think about patients who don't want to lay still. You have to think about getting paged all night long with catheters that don't work. We talked about data in the last wonderful presentation. Relining it, surprisingly, with covered stent graft does work. I don't like doing that because the runoffs on my patients are pretty poor. You need to have really good, robust flow, because when they go down hard. Laser excimer atherectomy is something that many of us will do. Others will use rotational. So if you look at the data, also the global subset from Impact Global looking at DCB showed us actually pretty good patency in the sub-cohort analysis, which is actually pretty good. So I think a lot of us have adapted when you're doing the ISRs to adapt DCB within the ISR. But here's what's interesting. Here's a patient, early 70s, had stenting obviously elsewhere, subacute left lower extremity foot pain. So you have a full metal jacket. The stents actually look nice on x-ray, but doesn't really do much for the flow at this point. Now, what's interesting is if the wire goes through pretty easily, I always think about this, that I am not that good. I try to pretend to be to my trainees, but I'm not that good. The wire goes through, there's an element of acute or subacute thrombus in there. There's that level of clot, whether you're dealing with a non-stented SFO or if you're dealing with a stented SFO. There's a cycle, right? There's hyperplasia, there's stenosis, and then you have some level of thrombus, which then causes occlusion. And then what happens is it depends on when you catch that patient. So in this patient, I actually prefer to do thrombectomy. So I do aspiration. I'll pass the, depending on what size at that time, it was a 6, might be a 7 or 8 French penumbra. Pull back, and interestingly, this is what came out. Now, if I had just ballooned this, I'm basically macerating this or smashing it against the wall. If I'm doing just basic atherectomy, I don't know what atherectomy will take out this clot. This isn't like congealed clot. This is some older clot that's stuck in there, right? So it's really important to think about what's happening in there and what are you doing when you just balloon, reline, all these things. And so just from thrombectomy alone, you might regain a channel, and then you can decide how you'd like to treat it. I do the same thing for long CTOs, a patient that I think is this incredible long CTO. It's going to be a long case like George is doing. But if the wire does this, you can see here, I'll just speed it up for completeness sake, that is not chronic, right? That's not all chronic. There may be some element of chronicity, but it's not all chronic. So in these situations, if I get through that pretty easily, then I will actually aspirate first, and then you'll find that there is a lesion that's underlying that caused all this. So those situations, I do laser because I can deal with thrombus, I can deal with plaque with laser, and then you can decide that this is all I have left. I can do whatever you want as your final treatment, whether it be drug-coated, whether it be scaffold, whatever it is. But instead of treating this entire lesion with the scaffold and creating the next ISR for me, I can do it that way. So, and that's what comes out, right? So we kind of coined this the laser cat technique. It's a freaky picture, but that's what we call it. And always, always, always in life consider protection, because every time a rep tells me, oh, this thing does not embolize, I 100% put a filter in. And sometimes you'll be surprised what you find in there. And often me and the great Dr. Ansari were just talking about this. A lot of time when we talk about embolization during procedures, I don't know necessarily if that's from the device itself always. A lot of times it's from that tactile feedback you need to have when you're doing these cases. When you push a device and there's plaque, you're sometimes just breaking the plaque off the wall. So that might be your embolization. So be careful with the devices, be slow, use protection. You shouldn't care about cost. We always talk about, well, it's too expensive to use this, but it shouldn't really matter when you're trying to get the right result for the patient. So it's not about cost, it's about doing the right thing. So I think if you're gonna do these things and do all these fancy tools, for me personally, I'll put a filter. So my approach with ISR, I first test with the wire. I see how easy it is. If it's easy to pass, I immediately go to a 7 French sheath. Then I'll try to aspirate whatever I can first. A couple passes there with the filter down. And then I'll decide, do I want to use atherectomy or not? Do I just want to do my final treatment with DCB? Or do I need to reline an area or just spot stent something? That's kind of my approach, and be very cognizant of it, because losing those little digitals and those tibials are very important for a claudicant. So that's my spiel. Thank you.